Good evening, everyone. Thank you so much for joining us today. I am Elita White Barnes, the project director for State of Black Long Island, also known as SOBLI. And I thank you all for attending today and joining the SOBLI Health Action Team's webinar entitled The Health Equity Issues of COVID-19, Connecting the Dots, What Everyone Should Know. And so what I'm going to do is turn it over to Dr. Henry to do the introductions. Dr. Henry, you're on mute.
Good evening, everyone. I have the honor of introducing the distinguished panel for this webinar. I want to thank them for their service to the community. Each of their bio is extensive, so I will give you a very short version due to the time limitation. Starting with Dr. Sean Smart, who is an assistant professor, director of Neurohospitalis Fellowship Program, Chief General Neurologist Service, Memorial Hermann Hospital, Texas Medical Center. Dr. Sean Smart attended the University of Miami, where he received undergraduate degrees in biomedical engineering, physics, and philosophy, while being part of the University of Miami Honors College. He received his medical degree from the University of Michigan Medical School. He completed his residency in neurology at the University of South Florida. Subsequently, he attended Duke University, where he completed 2 years fellowship in neurophysiology and epilepsy. Dr. Smart is currently in the Department of Neurology at McGovern Medical School at University of Texas Health, where he is a neurohospitalist and work closely with epilepsy division to expand their continuous EEG program. He's also co-director of Neurohospitalis Fellowship Program. Our next panelist is Dr. Toshi Iruko Melise, who is the inaugural chair of the Family Medicine Department and professor for the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell, and Northwell Health. In addition to her medical degree, she has acquired an MPH in health policy and management and an MBA. She has been involved in research efforts focusing on medical education, clinical outcomes, and innovation locally, nationally, and globally. Dr. Melise, she participates in global health initiatives and the interface of technology with healthcare provision while remaining active in advocacy work that allows for underrepresented population to be a part of the medical continuum. She has developed research programs for medical students, residents, and faculty across her department and utilizes state and medical specialty societies. She is a member of the North American Primary Care Research Group, where she has presented at their annual meetings for over a decade. Her laboratory focuses on academic and community-based research with a goal of developing innovative methods of providing medical education, clinical care, community outreach, as well as healthcare organization and policy. She's interested in improving overall patient care and clinician effectiveness. She graduated with her MD degree from the University of Nigeria, her MPH from Columbia University, and her MBA from the University of Massachusetts. She is board certified in family medicine, hospice, and palliative medicine. Dr. Karen Coutre. RN, PNP, PhD, has over 34 years of experience in healthcare sector, and her nursing career encompasses various specialty departments as staff and nurse manager at various hospitals on Long Island and as a pediatric nurse practitioner. She works on a mobile medical unit for 14 years at Montefiore Medical Center, providing health care to homeless adolescents, incarcerated youth, women, and children throughout the five boroughs. Dr. Couture has also participated in global healthcare initiatives and outreach in Ghana, Santo Domingo, Jamaica, Guam, and Haiti. She also developed programs in clinical and community, both in the United States and internationally, that enhance health promotion and wellness for diverse population she served. She's an assistant professor at the Long Island Educational Opportunity Center, Farmingdale State College, and received her master's degree in a nurse practitioner certification from Stony Brook University, our PhD from the University of Phoenix. And now our moderator, Adusua Watson, has been with the Suffolk County Department of Health, Office of Minority since August of 2008, and is currently serving as acting director of the office. In her capacity, Mrs. Watson coordinates community-based initiatives, co-chairs and sits on multiple committees and consult on programming and addresses health disparities, health promotion, and community collaboration. She holds a BA in psychology and a master's degree in public health in social behavior and community health sciences from the State University of New York at Albany. Mrs. Watson is a strong public health advocate who is passionate about challenging unequal systems, recognizing the power of community engagement and centering equity in all that we do. And now I turn the program over to Ms. Watson.
Thank you so much, Dr. Henry, for that amazing introduction. And I am so grateful and honored to be able to moderate such an esteemed panel. So with that being said, tonight we hope to discuss concerns around vaccine efficacy, building confidence in vaccination, and addressing long-term health effects associated with COVID-19, such as brain fog. And the CDC uses the term long-term post-COVID conditions described as 4 weeks after first being infected with the virus that causes COVID-19, just to frame what long-term health effects they're referring to. So with that being said, I want to get right into the conversation and open it up with an overview of COVID from our practitioners tonight. So the disparities with COVID-19 have been unprecedented, impacting Black African-American communities, Latinx, Hispanic communities, and our indigenous community, with them being more likely to be infected, hospitalized, and to die. So can you all share why we have such a glaring disparity in COVID-19 outcomes? And this is open to all of the physicians.
I can start.
Yeah.
Really, it's because at the end of the day, you have to realize it's because we have long-standing systemic health and social inequities. That, you know, that's the bottom line. That's the basis of it all. And so that has allowed those people, our individuals, the people in our populations, their baseline for health is lower than those who are not people of color. Right, so they're more at risk of getting sick and dying from COVID. The social determinants of health affect them in a different way because historically, they've not had the same opportunities for economic, physical, and emotional health. So they are living with issues and health risks that have predisposed them to being sick or dying from COVID-19. And we've got discrimination, that's been there in terms of racism, healthcare access and use, the work life, education, incomes, wealth gaps, housing. It's interesting. I'm going to say that we had a conversation earlier today with Dr. Kamara Jones, and she's used to be the president of APHA, and we were having this exact same conversation. And the way she put it, was very interesting. She's saying, we have these excess deaths of the people of color from COVID-19 because we're more likely to become infected because we're more exposed and we're less protected. And the reason we're more exposed is because a lot of us were in frontline workers, right? And that essential workers working in factories, working in the supermarkets, transportation, et cetera. And then crowded housings. Then we're less protected because we weren't giving that benefit of the doubt in terms of public health safety prior to the event. And then once infected, we're more likely to die because we are more burdened by the chronic diseases, right? Hypertension, diabetes, lung disease, and we have access to healthcare. And even when we do get healthcare, there's the issue of racism, structural and institutional racism, where we're not getting the care that we need. And so looking at structures, that racial segregation coupled with the disinvestment, we're more exposed, the crowded housing, chronic diseases, limited personal protective equipment, because for our low wage essential workers, remember, they were driving the buses, they were in the stores, they were working in the warehouses without the PPE, right? They weren't getting the protected equipment. And then the testing centers and vaccination sites that were available were initially placed in affluent areas. So there was less access to those who really needed it. And then the whole idea of, racism, denial, saying that, okay, the Black population, the people of color, they don't want the vaccines. Well, some of it is hesitancy because of historically how we've been treated and experimented on. But the other part was that lack of access. If you can't get to it, then you're not going to go. How are you, you're putting it somewhere where you don't have transportation to get to. And then or if you don't have access to a computer to make that appointment, then that made it difficult. And then we still have that race, again, with the racism, the hierarchy evaluation by race, where, if they're not like us, then we don't have to worry about them. And if they're dying off, that's okay. That normalization, that indifference to the population. So that's basically how she put it. And I thought that was very interesting.
Wow, thank you, Dr. Tochi. You brought up so many topics within that statement. First and foremost, Dr. Kamala Jones is a powerhouse when it comes to equity. So I really encourage all to look her up and look up her definition of equity. And then you mentioned so many factors, but even the messaging that we were putting out initially, the public health messaging, which is we're all in this together, socially distant. How was that not equitable? Can Dr. Couturier or Dr. Smart talk to like the messaging that was put out? Did it make sense for underserved communities of color? What were you seeing in reference to that?
I can just, I would like to add to that there's also the cultural origin of it as well. I mean, you can have a message, but I always tell people your culture comes with you. You live in, even though I might live here, there is a cultural part that still exists, even though I'm living in America. And I tend to bond to my culture in that space. So I can remember, getting so many, this is what you need to do. Don't worry about this. You need to blend this. You need to put this together. There were many treatments that people had following, this outbreak of when COVID started. And the narrative was then also centered around there. And I think that when I thought about public health, I don't think that the narrative culturally was also addressed. Okay, so there was a big part that was missing. So when we looked at New York and we looked at primary areas like Brooklyn, and we looked into the pockets in Queens, and when we looked at the pockets in Bronx, and you're looking to see what is the cultural origin from that group, you had where when you went to speak to people, they were not really interested in listening to the other narratives because there were people from their own countries speaking a narrative to them. And therefore, that was a driving force more than listening to what the CDC might have been saying or what the government might have said. They paid attention to what they know works in their culture. You could always think of somebody who was going to bring something to the table to solve the problem that you're having. Doesn't necessarily mean that it would work, but people turn towards the things that they feel more comfortable with than those that they feel unsure or not comfortable with. So, when we think about all those other narratives, I am always thinking about the cultural origin, not just, and I met people from so many different cultural groups. In Santo Domingo, this is what we were told to do. In Haiti, we were told to do this. Jamaica told us to do this. Everybody had their own spin on how they were going to deal with this because their country itself was doing their own narrative, the people. And WhatsApp, great place to have discussions. There were radio stations. We don't necessarily listen to all the stations that are out there. We're going to come to the ones that we feel very comfortable about as well. And you'll be surprised to see how many platforms there are to drive the narrative that, that deal with you culturally.
That's an excellent point. Yes, Dr. Smart.
So what I would add to all of this, just from somebody who's primarily in the hospital, I think when I looked at it, there was exactly what was said before. The messaging and the way it was set up, there was two folds. You had a system where you have a lot of minorities that don't have health insurance. That's number one. Then you have a culture with a lot of minorities where we don't, especially because you don't have health insurance, you don't necessarily go to the doctor when you feel a little bit ill. You wait, right? Because nobody wants to pay that money unless something's really wrong with them. Now you combine that with a community that has a higher rate of health issues. And what we saw was by the time a lot of the patients came to the hospital, their respiratory compromise, by the time they started feeling ill, they've lost so much of their respiratory reserves that it was a more uphill battle to fight to help. While you had some of the other patients where they would go to their doctor, they got checked, and as soon as they got checked and something was wrong, they got admitted to the hospital. Like, one of my residents, he just had a chest tightness, but because he had insurance. So he went to the doctor, turns out he had COVID, he had a pleural effusion. And he was like, I didn't even think much of it, but it was just fortunate that he went to the hospital when he did, and they found a fluid around his heart. So you have a community that everybody, you have a community that has more health issues. They don't have health insurance. But we're not telling them, hey, you know what? Don't wait till you feel like you really can't even go up a flight of stairs. Maybe once you start having any respiratory issues, like for example, what I told my mom when she got it was buy a pulse ox, which is like $10 at the store, and follow your pulse ox. Because that minute your pulse saturation drops below 90%, you need to go to the hospital. See, those are the things for some reason never got out as messaging. We told people wait till you felt sick. By the time you were feeling sick, by the time you were feeling that you couldn't ambulate, couldn't walk, your respiratory compromise, you're already significantly respiratory compromised. So what I would tell my friends and everybody who worked frontline, who had, wear your mask, do those things. But for me, I had a pulse ox at home. And I literally, every day I come home from the hospital at least once or twice a week, if not more, I test my pulse ox. Because I understand that if my respiratory saturation starts dropping, that's what's going to kill me. And that's, I think, a message that was not communicated very well, taken into consideration, the lack of medical infrastructure that we had, and the culture of the people who lacked medical infrastructure to say, okay, fine, do these things at home. Maybe you don't have a pulse ox, but you know what? Go up a flight of stairs every day. And if you're able to go up the flights of stairs before and you can't now, or you find it more difficult, go straight to the hospital. Those are things I wish was done or communicated better from my perspective.
Yeah, powerful. It's so important that we have appropriate messaging.
Right. And I'm going to add that you have the messaging, you have the culture, you have the racism, but then also remember that the communities themselves, the vulnerability, we want that social vulnerability. So there's something that you call the social vulnerability index, where it just ranks people, ranks communities, right? To see how vulnerable would they be in an emergency like a pandemic? And we've had this social vulnerability index for decades, right? Before we even knew that we were going to have COVID. And it takes into account different things that are happening in that community. And unfortunately for us, we have the score is basically 0 to 1. So if you're 0, you're safe. If there's a pandemic, an emergency, you're okay. And the closer you are to 1, then that means you're very vulnerable. And this is a place that, you know, in terms of if you have to evacuate or take care of these people, there will be a problem. And it takes us to, do they have special needs? Are they elderly people? Are they living close together? You know, what do they have supplies? Things like that, you know, that type of thing. When we look at Long Island, right, because I'm thinking, because this is the audience that's here, if you look at that social vulnerability index, would they have had an issue in the midst of a pandemic? And we've known this from time because they check it almost every 2 years. As of 2018, a year before COVID came out, 2019, and hit us in 2020, Suffolk had an index of 0.22. So we said, okay, not bad. Nassau, 0.24. Okay. Queens, 0.62. Bronx, 0.99. So, I mean, and these are the places where you saw the trucks with the you know, the freezer trucks with the people who had passed away from COVID, because we knew that they were the most vulnerable. So the problem, a part of it was that we knew they were vulnerable as a society, public health, those who were in public health knew that these places were vulnerable, but our public health infrastructure was not in place to take care of them and to protect these populations, so that when it came, I mean, they haven't been taken care of before. And then this incident happened. They already had this, you know, wariness of them. Then you have the culture differences, of course, as well. This is why it affected our community so badly.
Thank you for sharing. With all of these vulnerabilities that we know we have, and for some communities, it was an awakening, but for others, we knew this existed because we are in it every day. Excuse me, what can you share about what we need to do as a community to remain healthy, knowing that we have variants here? You know, what can you share about the variants and what we can do to remain healthy? You know, the public health measures, vaccination.
So I don't know who else I could speak on the variants.
Yes, Tochi. Dr. Tochi,
Okay.
yeah.
All right, so everyone now knows that there are variants, and viruses will always have variants. That's their job. Their virus's job is to stay alive. And so if you find a way to knock them out, they'll try and adjust and change shape or form so that they can spread more and find new hosts to survive. And that's why we have different flu vaccines that are adjusted every year because, you know, there are variants. So with this one, in terms of COVID, believe it or not, there are over 200 variants of COVID, but we have the one, so just to put it out there to begin with, but you know, they classify them. So the CDC classifies them as variants that are of interest, variants that we have to be concerned about, and then variants that are of high consequence. And right now we've got the ones that we're concerned about in the United States. So we've got the B117 that came from the UK. And for the audience that's here today, in New York, about 29.4% of the COVID that we have right now is that UK variant, the B117. The one that came from South Africa, the B1351, only 0.1% of New York has, you know, the New Yorkers have that, those who have COVID positive. The P1, which is from Brazil, we've got 0.3%. But the one that's been new came from California, B1427 and B1429, and in New York, we're 4.4%. And the rest, the 65.8% of that is the problem we have with these newer ones that are of concern is that they spread faster than others, and they seem to lead to more cases of COVID-19, that more symptomatic cases. So it's almost like when I explain it to people, I say, it's like COVID came, the first one came, and then as we found ways to combat it, it called its cousins, right? It said, come back me up. Right? We're gonna, you know, let's take this on. And so that's why we say that, yes, you have the vaccine, the vaccines are out there to take care of the initial one, but at least be protected with that one, because that will hopefully, it so far has shown that it's being able to take care of these new cousins, these new variants that are coming up. It's better to have that protection than to have no protection at all. But I'll let my colleagues speak to more of that.
There's not much I can add on the variants. From my perspective, just pure clinical, what I tell people is to think about the fact that, yes, this virus is going to mutate. You have to do everything you can to decrease the likelihood of you getting this, because what people don't talk about, there's certain parts of our population likes to harper on the survival. What concerns me is not the people who die, but the people who live. And I think this is part of the messaging that somehow keeps getting missed. The COVID virus that we're dealing with creates a cytokine storm that's an inflammatory state that is unique. And it's unique in that it creates the inflammation is high. That's why we're seeing so many organ systems affected. What concerns me, and we'll get into this a little bit later, is inflammation is bad for the body. It is fire to the body. It creates damage now, and it sets you up for long-term damage. So I think there has to be more of a conversation of like, hey, getting the vaccine will decrease your chance of having a severe case, which increases the amount of inflammation, that decreases your chance of getting a lot of long-term things. And I think for some reason, those are the things that we're not discussing with these variants or with everything that's happening, saying, hey, yes, you need to get the vaccine. It's not going to be perfect. There are variations, it may not keep you from getting the complete infection, but what you want to do is decrease the inflammatory state created by this virus, because we know inflammation increases your risk of Alzheimer's, inflammation increases your risk of heart disease, inflammation increases your risk of autoimmune diseases later on. There's even research that shows that increased inflammation increases your risk of certain cancers. So what we're doing right now by not having these discussions, we're setting ourselves up for long-term consequences from this inflammatory state that for some reason we're just ignoring. Well, not being ignored. The insurance companies are already taking into mind that COVID is going to be a pre-existing condition, because they know that there will be long-term consequences. But for some reason, when we talk to the public, we're not laying that out. That's why you need to be vigilant. That's why you need to care, because there's long-term consequences from this. And we're not even certain what all of this is going to be.
Well, thank you. I'm going to hold on to that bit of information that you shared, because about the health insurance companies and how they're looking at it, that dovetails into another question that I had. But what, as practitioners, what are the myths that you've heard around the vaccine, its effectiveness? What are some of the myths? And do you also think that the pause in J&J had anything to do with the recent reports out about there being some a downward tick in vaccine uptake?
I'll address it here because I had my concerns. I'll just put it out there. I'm a bigger fan of the J&J. I've gotten the J&J one, and I'll explain to you why. And not that I'm against the others. I think they're all great because my family all got the others. The concern that I'm hearing was the methods used for the others are RNA based, which doesn't change your DNA, does nothing that, but it's a relatively new process for being used in this manner. And the speed at which it was developed, there was some concern about not knowing the long-term consequences that may not be known. What I told my family though was, we may not know all the long-term consequences of doing the vaccine this way, but we do know the consequences of the risk of COVID. So, I tell everybody, everything in medicine that we do, everything has a negative consequences. Like, there's nothing that I give my patient that doesn't come with a risk, right? It's basically what we look at is risk benefits. Does what we're doing to the patient better than the risk of what the disease can do? And in this situation, I said, yes. Now, to me, everything with the Johnson & Johnson one, and the reason why I say I was a little bit more preferential to the Johnson & Johnson one is because the Johnson & Johnson one uses a typical process that's always been used to make the vaccine. So what I told my family, like my mom who runs an assisted living facility, you're around patients, you need to get the one, you've already been exposed, your patients are at high risk given your environment, you need to get the vaccine. You need to get the one you can get as quickly as possible. And at that time, it wasn't J&J. My brothers who were very active, always going out, I said, okay, you probably should you need to get the vaccine as much as possible. For myself, I wanted it as soon as possible, but for this past year, I've never been one that likes going out. I have a specially made mask that I use in the hospital that is airtight around, that I walk in the hospital and even in the grocery store that has a special filter in front of it. So I felt comfortable with the methods and I check my pulse ox regularly. So I was saying risk benefits for me, I was safe waiting for the J&J, and as soon as I could get it, I got it. I think, yes, there is some of the stories are depressing people's interest because a lot of people were waiting on the Johnson & Johnson because they just wanted to get one shot as well. And I think it does a huge disservice because, as I said, we have to start talking about the fact that there is going to be a side effect of everything. And the data doesn't even support that what we're seeing in terms of sagittal sinus thrombosis, which is my area in these patients, are actually due to the vaccine. Because we already know that this population who are getting these clots are already at a high risk of getting these clots, especially because, especially some of the younger ones, because birth control. We know that birth control increased the risk of these clots in females more than anything, more than the vaccine. But we don't have anybody pulling the birth control. We talk to our patients about it. So I think some of this is overblown, but I think there has to be an aspect where we're honest with the fact of is there going to be some risk? Yes, that's everything in medicine. But the trick is when you get the vaccine and you start having any symptoms, go to your doctor right away. That would mitigate any issue with the risk of the vaccine.
So I'm going to add on to that. So again, with the COVID-19 vaccine, the biggest myth, like was mentioned, is that people say, oh, it's going to change my DNA. And the vaccines don't change your DNA, and they don't interact with the DNA in any way. So you have the Moderna and the Pfizer, which are messenger RNA vaccines, and then you've got the Johnson & Johnson and AstraZeneca, which we're not using, which is that uses an inactivated virus that carries that message. But both of them, both types of vaccines carry instructions, genetic material to our cells, or the viral vector ones. All three of them deliver messages to genetic instructions to our cells so that they can build a protection against the virus that causes COVID-19. And it's usually basically, but that material that you're getting through the vaccine doesn't go inside the nucleus of your cell, because that's where your DNA is kept. That's where our DNA is kept. So it doesn't go into that part. So what it is just making sure that the genetic material, right, doesn't interact with our DNA. It just causes our body to now recognize that protein, that spike protein that comes on the surface of the coronavirus, so that it knows, okay, I've got to attack it. I've got to create a response to it. And so it recognizes. So it's like you're getting your troops ready for battle, so that the next time you're exposed to it, your troops are ready, and it's like, okay, we're on it. We're ready to go. And so that's the thing where people say, oh no, it's going to affect my DNA. It's not affecting your DNA. It's not going into your nucleus where your DNA is. What it is it's going in there to your cells, but it's just trying to create the spike so that your body recognizes it and your immune system is ready to fight it next time it's exposed to it. Another thing I will say is that the mRNA, I know a lot of people feel that it was created quickly, but the mRNA process has been in effect for a long time. In fact, they were trying to use it to create a vaccine for SARS, and MERS. So they used that process to create it, but it was not used because there was no pandemic. It occurred, there was an epidemic in certain areas of the country, of the world, I should say. And then, but it was, again, it's a pharmaceutical company. So there was no money to be made because there's only a small group of people that needed it. So they put it on ice, they put it aside. SARS came along, they put it. So when when coronavirus came, and remember, coronavirus is the SARS-2 because it's the second type, SARS time is coming around. SARS coronavirus 2, 2019. So that mRNA process of creating that vaccine was already able to be adjusted and adapted. So the SARS and MERS were basically adaptations of that vaccine. And so when this came around, it was easier to adapt to. And that's why Pfizer came out faster, because they were the ones that were doing this. And then now you have the whole world that needed it. Plus, you now had the entire world, because it's a pandemic, all scientists, all bets are off, trying to figure out how to fight this. So people were collaborating and everybody put all their resources and all their labs. I mean, anybody who works in labs or research knows that it's hard to get money from people to do research. And all of a sudden, the entire world was throwing their money at research, saying, okay, make it happen, do what you have to do. We need this out now. And usually we have vaccines in stages. We do stage 1, stage 2, stage 3. They actually had them in parallel to make sure that we got this out as soon as possible, because it was a pandemic. And so we had a circumstance where so many things fell into place, and we already had the base of the fundamental base for this vaccine already made, that it was easier to bring it out quicker. So that's the myth that, that it's that it changes your DNA. It's not true. And the reason it did come out quicker is because we had all the resources at our disposal, it's unique. Usually at pharmaceutical companies, and they knew they were getting paid because the governments are paying for it, right? It's free to us right now, right? So they knew they were going to get paid. Quicker.
I just want to piggyback a little bit on exactly what was shared in that and I had the same conversation with people who came to ask me, what did I think? Okay. And I can't say enough about what Dr. Smart spoke about, the long-term effects that we know could happen. And when I had conversations with people, that was the, again, as Dr. Henry likes to say, sometimes we need to be ambassadors in our own community. And so therefore, you're able to speak to people. Listen, Jamaica is taking AstraZeneca. I told my brother, listen, if that's the only vaccine that's available, you have to take it, because you are in this population that you need to be worried, because we know the medical stance over there. So when you have a conversation with people, you always have to ask where, what's the information you have, and see how you can share the information that is validated so they can make a decision as to why. And I can't say enough about the long-term effects that we're seeing, what it is we know it's going to evolve into, because we are seeing it. And one of the things that, the medical group had to come to face is that this is new to us. We're trying, it's not like it's cancer. You have the answers, you can dialogue certain things. The patient is going through it. They're trying to analyze it. We're all in the same place trying to figure out exactly what is going to be happening with this COVID. So it's better to be preventative than not. So, in terms of sharing all those different factors, definitely, asking people, what do you know about this vaccine? What are your fears? And then you can probably launch into a conversation that can possibly get them from being a non-participant to a participant.
Thank you. Dr. Couturier, can you share your personal perspective on being what is termed a long hauler? Can you share with us what that means?
Yes. So I am a long hauler. Okay, I was one of the first group when COVID came out in February. I was diagnosed in March 25th with COVID. That's 1 month after the country went into the shutdown. And I can remember, the first thing, and I can't say enough about having preventative medicine or have a profile of preventative care. So what happens is you have to kind of know yourself. So the first thing I know is I'm not a person who gets a fever. I don't tend to be short of breath. You know, so the first thing, those are the first two identifiers for me. I can remember it very succinctly. It was a Saturday. I looked at it. I said, my temperature is up. And I remember going up a flight of stairs, exactly what Dr. Smart said. If you go up a flight of stairs and go down a flight of stairs and you can't breathe, there's a problem. So I went up the flight of stairs and I literally thought somebody was sitting on my chest. My husband was sitting in the living room and I laid, as I got to the top of the stairs, I laid down. And I said to myself, I wonder if I have to call him to come and do CPR, because I felt like my heart and my lungs just was crying out for this oxygen. So I literally crawled on my all fours to my bed, and it's like inside just said, you need to lie down. You need to lay down for about 20 minutes. After about 20 minutes, I finally began to feel like I could catch my breath. By that time, I'm texting my husband. He's in the living room. I couldn't even call him. I said, you need to come in this room and sit next to me in case you need to provide some healthcare for me. Now, I'm the healthcare person in my family. But one thing I made sure, everybody knows CPR. Because if I need CPR, somebody needs to help me. So the very next day, I remember calling my car. Saturday, Sunday, my fever went up a bit. I felt very lethargic, same tightness in the chest. Monday, I called my cardiologist and I said to him, the first thing I noticed, I had a metallic taste in my mouth. I didn't feel like eating anymore. I felt like I had this metallic taste. And I called him and I said to him, you know, I think I have this COVID. And he said to me, what are your symptoms? And I told him, he said, no, those are not the ones that they have on the list. Remember, it's early stages. They didn't have loss of taste, loss of smell, you know, all these other pieces that I'm describing to him. And he said, you know, let's just watch this for a while, okay? So Tuesday came. Wednesday, I called my primary care physician. I said, listen, you need to listen to what I'm telling, you know, I'm telling this. He said, pick yourself up and go to the ER right now. Go to the emergency room. Tell them you're a first responder, you're RN. They're going to see you right away. You have to remember that when COVID came out, we didn't have rapid tests. It was systematically going to be given to you based on who you know, whether you fit into first responder or whatever. So I got into the ER, and thank goodness for that ER doctor. He said to me, he wrote a letter. My primary care said, I want to do a chest x-ray. The emergency room doc came and he said, I'm not doing a chest x-ray because I don't think you want to see it. Okay, what I'm going to tell you is to get a pulse ox, take your pulse ox, and here are the ranges you need to look for. If your range goes down to these levels, you need to bring yourself back into the ER. You need to hydrate yourself. Do not lie in that bed all day. Get up and walk around. Feed yourself, eat your foods. And he gave me a whole list of things that I had to do. Hydrate. So I came back home and I followed exactly what he did. Okay, so I came through it. I remember you never knew the test results right then and there. So I literally was in quarantine for 3 weeks. By the time the Department of Health got the test results 1 week later, I'm telling the nurse, I have been in quarantine. Nope, we're doing it from this day forward. So I had 14 days after that to stay in quarantine. I literally thought I was going to go nuts. So in my household, I have 5 people living in my household. My mom, who is 90, other people in my household. I have 2 people with comorbidities I have to really worry about. They have autoimmune diseases. I pushed for them to go and get the test. And I finally said, you have to test them. So the same day I came out of quarantine, they got the results that they were all positive. I then became like a ward in my house. Everybody go in this room, stay over here. I literally did exactly what they told me to do. Make sure everybody have food, keep isolated, followed every principle that they were supposed to have. Took the pulse ox, the temperature 3 times a day, like I was a nurse on shift. And nobody ended up going to the hospital. Everybody came through COVID, knock on wood, you know, without having to go to the hospital. So after we were finished with the COVID scenario, it was about the 3rd. It took me a while. I'm a person who walks about 3 miles a day, maybe 5 miles on Sunday, up to 7 miles. For me to get back, I remember the first time, 2 months later, I went out to the track. I walked exactly 1.5 laps. And I felt like how I felt the day I got COVID. And I said, I have to go home. And then that made me say, what else could this thing be? And so, you know, they didn't have the term the long haul at the time, but I started having things that I noticed in my body that was not normal for what I normally went through. So the longevity of the story was, by the time I went in November, they started bringing out what they call post-recovery, COVID recovery teams. And I remember walking into my primary care and I said, what's this? I see this in front. And she said, oh, you know, it's for people who want to go and have post-recovery follow through for COVID. And you know what was the funny thing? I had many things that happened along the pathway. I remember having brain fog, thinking, am I having Alzheimer's? What is this going on? I remember the shortness of breath that was PDR, you know, every now and again I had a chest pain. I kept wondering, what are all these things that are happening? My skin, for the first time in my life, I came up with some irritation on my skin. I'm saying, and what I've been doing is following up with the physicians and saying, could this be related to COVID? And nobody said, yes, it could be, maybe it was not. When I got to that team of people, and for the first time when I said to him, you know, I actually lost consciousness and fell down a flight of stairs. And I could, until this day, I don't understand. I look at those stairs and I'm saying, how did I go down this flight of stairs? Is it that I lost my, you know, did I have dizziness and fell down the flight of stairs? And for the first time when I actually went to those physicians and I spoke to them, they had been following over 960 residents. They actually worked in the hospitals, and they decided to create a team and follow all of these COVID hospitalized patients post-recovery. And so by the time I got into there, they broadened the scope. And it was the first time I heard somebody saying, yeah, all these things, yes, they're COVID. They're related to COVID. Mm-hmm. And so they took me under their wings, and I have had pulmonary studies done. They put me into rehab. March into April was the first time my body actually even felt like this is me. Okay. And so the one thing I do have, and when I read the paper, you don't know when the symptoms are going to come. You don't know how they're going to come. So 2 months ago, tinnitus started happening. And I'm sitting here going like, are you kidding me? And again, when you look at the symptoms, it doesn't have to follow the patterns, but it can be from that. So, you know, it is important for me when I say, to have a preventative care model. When they said to me, we want to look at your cardiac workup. Do you have a history of cardiac workup? Yes, I do. Oh, I was there 2019, went to my cardiologist 2018, 2020. When do you want the results? And so they could literally look at past history and look at what is happening to you today. So I can't say enough about making sure that we do stay on that path of preventative care, because again, you don't want your baseline to be the first time you're having issues. Yeah. So knock on wood, I finally came through all of these other tests. It's like April is the boom month where my pulmonary status is back to being where it's supposed to be. Cardiology is there. Diffusion, I have a small amount, and they say it will go away over time. You know, it's physiological. So, you know, Dr. Smart, when you are saying these things and I'm listening, yes, I am a candidate who has walked through there. My family is doing the same thing. I've put them into these, you know, my mother is 90, she goes in, I say you need to have a follow-up because we don't know what it's doing in our body. So the long haul of what it looks like, it's better to know now than later. Yeah. If you don't pay attention to it now and give yourself 10, 15 years down the road, you might not be able to turn back that clock or get yourself to a wellness level that is functionable for you to be able to go through.
And
so,
I see,
you know,
and I see
that journey.
I'm sorry, I wanted to link you to, there's a comment in the chat that actually speaks to what you were referring to, Dr. Couture. Someone was mentioning that their daughter was denied a test, worked at the hospital, and she still cannot taste or smell. So this is, you know, folks who were going in for care and were denied certain care, even though it seems like she works in a hospital, that means she's an essential worker. There is also another comment, what do you do if you don't have insurance? So what do you do when you don't have insurance and you have post-COVID syndrome?
I think one of the big realities that we're seeing now is that more of the medical models are realizing this post-COVID recovery. You know, like I went into one outside of my of the area of my where I normally have my medical management, and then next thing you know, I noticed my medical management also has it. So I think in terms of, I think the medical society is waking up to the fact that you have these long haulers and they need to address this. Now, in terms of, I sincerely hope that, you know, the research is being done in this area as well. And I think I'm trying to figure out how you would tap into looking for a research program, because they want to hear the story from you and they want to follow you and they want to make you part of their research that gives them you know, an understanding. And one of the reasons why I particularly went there is because as a person of color, we are the ones who are less likely to go into research initiatives. So you only get one slant. So, you know, I purposely said I'm joining this program because I want to be able to share my story as an African-American having COVID and a long hauler. So I would say that maybe, hopefully we can, if I had my phone, I can probably even look and see, Google it and see if there are post-recovery programs that have no insurance cost and they'll be willing to take you in to then begin the care, because it is going to be very important.
Yes, and just to add to that, Ms. Woods, if you are on Long Island, Suffolk, Nassau County, we do have federally qualified health centers that will take you regardless of your insurance, regardless of your immigration status. So if they need care, please, like Dr. Couturier mentioned, link to a practitioner and get regular care.
Right. And I'm going to add to this, because the federally qualified health centers, they're also eligible because we have the National Institutes of Health, right? That they, NIH,
yes,
announced that they have a first phase, the first phase of a 4-year, is going to be a 4-year $1 billion initiative to learn more about some COVID-19 survivors, the long-term symptoms, and even, you know, for those, because it's not, what we've learned now is that it's not just people who were hospitalized who have it. There are people who were at home who had it, and there are even some asymptomatic individuals that happen to have been positive who are now showing signs of the long haul disease or post-acute, you know, the SARS.
And I would add something else that I'm seeing in the hospital that is blowing my mind. I had a patient whose husband had COVID. We think she had COVID. Her PCR was negative. Antibody test was negative. So we know that she didn't have it after her husband because her husband was sick with it. But at some point, I was pretty certain she had COVID because she presented it in the hospital with a COVID encephalitis, what I figure was a COVID encephalitis, meaning this was sometime after she got infected. She was intubated, sedated, confused in the hospital. We tested for everything. We could not figure out what was going on. What we did though, we're like, look, even though everything is negative for COVID 3 times over, we treated her like she was a COVID encephalitis. We pulse steroids her for 5 days. By 7 days, we were thinking she needed rehab. She was ready to go home with her husband. So there is this aspect, there's going to be people who never get tested, or even when they get tested are negative.
That is true.
You have to be vigilant, because I'm seeing patients who come back negative and they look like it. And some of them I don't have that family member sometimes I don't have that family member who's clearly positive that I can say, okay, this has to be COVID, but I still treat them like they're possibly COVID, meaning like the other lady had respiratory issues and neurologic issues. Everything looked like COVID, but everything COVID test was negative. We treated her like COVID and she recovered. And what we're finding, at least some of the neurologic studies that are looking at this, while there's multiple different theories of why this is happening. There may be an inflammatory aspect, but also in some of their biopsies, they're finding that the virus is embedding itself in the brain somehow. And the problem with that is if it's inside the brain, there's nothing we're going to test that's actually going to find it, unless you die and we do a biopsy. So this is why, like, it bothers me so much when people talk about just the mortality of this disease, because there's so much more that is happening. I mean, at least from a neurologic point of view that I'm seeing, and I know cardiology and respiratory are seeing similar things. The virus is doing so many different things to the body. And I think everyone has to be aware of what's coming. And if there has to be a push, if this doesn't cause a greater push for universal health care, I don't know what will, but I think us in the medical community have to point out there is a wave coming. there is a wave that's coming from what's going to happen to the people with this disease. And we're already seeing some of it hit the hospitals. And this is only not even a year out yet. And I think it's going to get a lot worse. And if we only think, okay, you were positive for COVID or you weren't positive for COVID, I think we're going to miss a lot of these patients. I think we have to focus on and we have to educate the public on what are the long-term symptoms. And I don't care if you actually never had a positive test. If you have the long-term symptoms, you need to be treated as if you were. Because early on, as you pointed out, a lot of people didn't get the test.
Yeah.
The test has a lot of false positives and false negatives. So, you know, we have a long way to go. I don't know if our politics and our society has what's needed to fix this, but it's going to hit us one way or the other.
But there is an advantage in Long Island, in New York, this area. We have a lot of centers that have popped up now that are treating post-COVID for people who have had COVID or are having symptoms of post-COVID illness. So even if you're asymptomatic post-COVID, you're supposed to go there. If you and primary care the primary care docs and its medical societies, that's all the CME now, they're teaching everyone is how to handle long haul COVID, how to handle anyone who's post-COVID, whether they're symptomatic or asymptomatic, and what are the symptoms and signs, and how do you manage that? So there are resources now. There's a lot.
Is there a link for that, Dr. Tochi?
Yes.
Is there a link for that where folks can find information?
I will give you. I have a link for. I have the link for the organization that I work for, and I don't want to be biased in this, so but I will put it in. But there's a CARES program, CARES. If you click on Northwell and look for the CARES program, and then there's the CROWN program, CROWN. And if I can, I'm going to pull that up and put it in the chat because I know the time is going. So let me pull that up.
Yes, thank you. This was an excellent conversation. Is you know, there was one more question in here, and I don't want someone, if you can briefly answer it, about the new requirements with masking outdoors. Thoughts of lifting the restrictions of masking while outside. What are your thoughts on that? And then we will move to Ms. Alita to close us out and provide us resources.
I think it's good. I'm not concerned about it. I mean, we already have the data. If you look at states like Florida that has had a very liberated policy in terms of treating COVID, one of the reasons their numbers are a little bit lower is because of the weather and people being outside. So now you combine that with the fact that they're saying to do so for those patients who are vaccinated. And I think the risk in that point, I mean, of course, you're never going to eliminate all the risk, but I think that's a relatively safe approximation, meaning you're outside, you're vaccinated, the likelihood, you know, is low, lower, nothing is zero, but I think that's a good way to, one, incentivize people to get the friggin' vaccine, but also without increasing the risk to the population.
And I can say that and I agree with exactly what you're saying, Dr. Smart, because I mean, being outdoor, when you're indoor, it's a closed entity. When you're outdoor, you know, the disbursement of, you know, respiratory it's a vast amount. And the other piece is vaccination. I mean, I have no qualms asking people before they come to my house, are you going to be fully vaccinated? And it's, you know, and I've gotten to the point now, listen, I have a mom who is 90 years old I have to look after. You can show me your card, okay? You can come and you can have a seat in my backyard, you know, you can come, but, you know, if not, if you choose to not be that person, then, you know, it's okay. You do not have to, you know, in terms come and intermingle, but I agree with that. You know, you have to be vaccinated. You want to be vaccinated because it gives you a little bit more freedom. And then you're able to be and use your consciousness, you know, use, as my son likes to say, situational awareness. You know, when you come into a place that is very crowded and you have to put your mask on, it says 6 feet apart. If you're in a wide area, I walk a lot. I can walk on the boardwalk. I can choose to walk on the beach. If I'm on the beach, less people are on the beach. That's easy for me to do. You know, so again, you know, it just gives you a different set of matrices to play around. So get vaccinated.
Thank you so much to all the panelists. There was not enough time to address all of the questions, and thank you so much, Dr. Tochi, for putting the link in the chat. Please check, you know, copy that and share it Please also know that there are a lot of walk-in vaccination pods throughout Long Island, so look those up. So Elita, who is the project director of SOBLI, I'm going to pass it to you. Thank you again.
Well, thank you all for your participation. I'd like to do a special thank you to our panelists. We appreciate your time, taking out your time. I know you guys are being pulled in a number of different directions for a number of different webinars. So I'm glad you accepted our invitation, though you all have the link to Dr. Henry, and we don't say no to Dr. Henry, but I'd like to say thank you anyway. I'd also like to acknowledge Dr. Henry as well as Jessica Watson for representing the SOBLI Health Action Team. And on behalf of our President CEO, Teresa Sanders, I'd like to say thank you all for coming. I'd like to also share some information that the Action Team put together as resources for additional support for information on the topic for today. And what I'm going to do is send this out to everyone who registered for the call, so you don't have to worry about trying to copy down this information. But like I said, again, thank you once again. If there are any questions that we didn't address that are in the chat, what I'll do is make sure that I get it over to the panelists. I just want to check real quick. This has been great. I learned a lot on this session, and I definitely appreciate your time. So we are at the end of our time, and thank you very much. Have a good night, everyone.
Have a good night. Thanks for having me. Take care.
Good night. Thank you.
Thanks for having me, and take care.
Thank you.
Thank you for coming.
Thank you. Great information. Okay.